Great. Well, thanks everyone for joining. I think we're at a good point to go ahead and start our presentation today. So we are presenting qualitative and mixed methods as part of our CIIS Center for Implementation Improvement Sciences Implementation Science Education Series. And today's presentation will be presented by myself. I'm May Ansari and Marilyn Drainoni as well. So first, to talk for a minute about who we are, if this is your first time joining us, welcome. As I mentioned, we're the Evans Center for Implementation and Improvement Sciences. So we are a methodologic hub for implementation science and safety net setting. What we do, we provide guidance, support, and innovation in research design, and we also educate the BU and BMC community on implementation and improvement sciences. There are different ways to engage with us, one of which is this monthly educational seminar, and we also offer research consultations if you have a project in mind and would like to speak with our team. And you can learn more about us at our website, as you see there, or send us an email. This is the CIIS team. So our director is Marilyn Drainoni. Kirsten Osted is our co-associate director, and she's based in family medicine. Nick Bosch is also our co-associate director, and he is in the Department of Pulmonology. Santana Silver is our assistant director. Kayla Jones is our research specialist. Gabby Cordova is a neonatologist. She's a prior fellow and now faculty member. Catherine Fantasia is a former fellow and now faculty member in CIIS, who's based in endocrinology. Shana Burrows is a current fellow in infectious diseases. Myself, I'm in developmental pediatrics, and I'm a current fellow. Katie Rislow is a nephrologist and a co-fellow, and Rebecca Rudell is an infectious disease and also a fellow. So today is our last seminar series for this year, but you can we have all of our videos are on YouTube, and you can use the QR code there to watch our previous seminars. And so for today's discussion and talk on qualitative and mixed methods, our learning objectives are to explain why qualitative methods are used, to define and differentiate various types of qual methods, to understand sampling methods in qual work, to understand common terms that are used in qualitative research, to understand how qualitative methods are used in implementation science, and describe aspects of rapid qualitative approaches and mixed methods designs. And as usual, we're going to end with a case discussion that will hopefully help kind of illustrate some of these concepts and how qual and mixed methods are used in implementation science. So first, why use qualitative methods? So qualitative research produces rich descriptions of phenomena that are not available through quantitative data. And we use qualitative methods to really describe complex settings and interactions, and also really enhance our understanding of context. Qualitative methods can also be used for theory development, which is one of the more traditional uses of qualitative methods, and also to identify patterns. In implementation science, we often think about qual methods as helping to give meaning, or the how and the why to the what of the research practice gaps that we're trying to address. And qual methods are finally really good for telling the story. So what are qualitative methods? These are interviews, focus groups, ethnography and observation, document review. We'll talk about each of these individually. And one thing to point out, the qualitative methods are not things like surveys or large EMR data sets. And finally, implementation is not qualitative methods, but qualitative methods are increasingly being used in implementation science. So first we'll talk about qualitative interviews. So really a qualitative interview is a one-on-one conversation that's designed to elicit depth on a topic of interest. Usually they're open, they consist of open-ended questions with inductive follow-up probing based on what the interviewee says. Qualitative interviews should really look and feel like a conversation. These are typically recorded and transcribed verbatim, so that the words that are used are really the data that we're getting, the qualitative data. The strengths of qualitative interviews are they're really good for understanding individual perspectives or experiences. Some of the limitations are that they're labor intensive to do individual interviews. You may miss perspectives depending on who you are, who your sample is and who you're interviewing. Qualitative interviews also require training and skill to be able to facilitate. So a good interviewer can get really great data from a qualitative interview, and someone who maybe has not been trained or has less experience, it might take them a while to get really comfortable doing qualitative interview and probing. Another method are focus groups, and these are carefully planned discussions with a small group of people, usually 6 to 10 is ideal. Less than 6 and you may not have individuals interacting together, and more than 10 may be difficult to manage. Focus groups, usually the group is discussing a focused topic, and the individuals in the focus group are really discussing their experiences, opinions, perceptions, and reaction. The group setting and group dynamics are really integral to the focus groups, to the conduct of a focus group. So people are interacting with each other and you're having back and forth between group members. Often, especially in implementation science, you need some similarity in the group. So characteristics, experiences, or situations. We might think about, focus groups having, for example, like a similar level of providers in a focus group. So maybe it'd be a focus group among clinicians or a focus group among social workers or among community health workers. The discussion needs to be moderated by an experienced researcher. And some of the strengths of focus groups are they're really good for generating ideas. They can be a really fast way to collect data and allow of generation of ideas between individuals. So you might get more different ideas than you would get from individual one-on-one interviews. And you can also observe in group interactions. Some of the limitations of focus groups is that they're not good for kind of eliciting personal experiences. Also, with regards to group dynamics, quieter people may not speak up or feel comfortable sharing their experience with others. They may not be good for all populations. There is a risk of confidentiality in focus groups, depending on what, in terms of sharing information, participants sharing information in a group setting. And focus groups require really strong facilitation skills to be able to ensure that all focus group members' voices are being heard and that the conversation is helpful for the research question. Another qualitative method is ethnography and observation. This is kind of the classic work that people think of when they think about qualitative methods. It's the work that Margaret Mead did when she went into the field. So ethnography or observation is a systematic recording of events, actions, and interactions, and gathering this through direct observation. EDIC refers to an outsider looking in and having that outsider perspective in an ethnography. And EMIC is if you have an insider and who's already in the community doing that ethnographic observation. If you are considering using ethnography for multiple events, you might consider using the same ethnographer over time to build trust. And then once your ethnographic data collection is completed, you would post hoc use field notes for your data analysis. Some of the strengths of ethnography is that it captures behaviors and patterns that individuals may not be aware of. So different from interviews where you're asking people their opinions or beliefs, but with ethnography, you're really able to observe what behaviors or what things people are doing in the community. Some of the limitations that it's extremely labor intensive and may be considered intrusive, or it could limit what is shared or what is done in a community setting, having an outsider there. And so it becomes really essential with ethnography to gain the trust of the group. Another qualitative method is document review. So here you're not actually collecting data, but you're reviewing source documents that were generated. So some example, you might look at meeting minutes, mission statements, policies and procedures, clinical practice guidelines. You usually will have a template for what you want to review and the data that you want to abstract from your document review. The strengths are it can maybe easier to collect the data, but some of the limitations are they can be difficult to contextualize. And, with the documents, it's not an actual recording of what is happening or of people's opinions. You're kind of limited to what the document is. These are some common qualitative definitions that come up. So I'm not going to read through each of them, but just know that the slide is here. So in the future, if you need to reference it, it could be a resource to you. All right, and now we're going to talk about mixed methods design. So as I mentioned, qualitative methods can be used alone or in combination with quantitative methods. And I also mentioned that qualitative methods are being increasingly used in implementation science. And most often in implementation science, we're using both qualitative and quantitative methods, or mixed methods, as they're called. So often when we're doing pre-implementation studies in implementation science before launching an intervention to understand the context, we may use qualitative methods alone at that phase in the design. There are three different mixed methods designs that we're going to talk about. The first one is a one-phase design, and it's called the convergent parallel design, as you see at the top of the screen. So that is when quantitative and qualitative components are conducted at the same time. So you're gathering your qualitative data, you're gathering your quantitative data. Both methods are given equal weight, and then you're analyzing both the qualitative and the quantitative independently, and then triangulating and interpreting them together at the end. So some examples of a convergent parallel design might be if you're collecting EMR data on intervention implementation in parallel with interviews with the implementers. You may be observing workflow, conducting interviews with implementers, and obtaining metrics from an administrative data all in parallel. The next design is a sequential explanatory design. And so that is when quantitative data is collected first, and then those results that you're getting from your quantitative data are used to inform the qualitative phase. So you're trying to then use your qualitative methods to really understand some of the findings from your quantitative methods. And this really allows for contextualizing or understanding the results of quantitative findings in a deeper way. So some examples might be, for example, like, as I mentioned, conducting a survey, analyzing the results, and then you're really basing your qualitative questions in those survey results to give you more understanding of them. And then finally, sequential exploratory design is when you are first collecting qualitative data because you want to gain insight into an unexplored phenomena, and that would allow you for the creation of theory and hypotheses to be studied in a more generalizable way in your subsequent quantitative phase. So for example, you may use qualitative interviews or focus groups to then inform. You might use qualitative interviews to inform a survey, or you may choose to use a focus group to generate some theories that you would then examine quantitatively. And then just briefly touch on different sampling and qualitative methods. So we'll start with snowball. We'll talk about snowball and theoretical samplings as kind of how you get your participants. So in snowball sampling, you're looking to recruit participants who fall in, say, category X, and then you would ask your participants if they can recruit additional participants and have them reach out to the investigator if they're interested. So snowball sampling might be particularly helpful if you're trying to recruit participants in a tightly networked but difficult to access community. An example might be if you're doing research with sex workers, for example, and so snowball sampling might be really effective for a way to recruit additional participants. We also think about, there's also theoretical sampling where you're sampling people based on their emerging you're adding cases based on the understanding of the field and or kind of some emerging hypotheses or theory building that you're getting from your ongoing data analysis. So you're doing your data analysis and you think, well, now I'd really like to talk to X person because they can provide me with this additional understanding. And theoretical sampling really requires ongoing data analysis so you can then identify who you'd like to sample next. And then for all of these, for both of these approaches, we really think about in qualitative research sampling to thematic saturation. So this is really thematic saturation is essentially how we think about our sample size and qual methods. We're not identifying an a priori n or a power of a study as you would in quantitative methods, but rather we're continuing to collect data, analyze the data, and then and stop data collection when no new themes are identified. So you might sample to saturation, but you might recruit your sample via snowball sampling or theoretical sampling. Some additional sampling techniques and qualitative methods. One is maximum variation sampling, where you're really trying to get the most variation in cases and ensuring you're covering the widest range of types in a population. So you're really trying to get variability across the group, and that's how you're deciding who you are enrolling in your qualitative study. There's also extreme or deviant case sampling where you're looking for unusual cases. So often, for example, you might think about the best or the worst. So if you were doing a study on childhood diabetes, you may try to enroll kids both who have very poorly controlled diabetes and maybe kids who have exceptionally well-controlled diabetes. Convenience sampling is also commonly used. It's essentially non-random sampling of individuals based on who you might have access to. So this might be suitable for kind of exploratory or pilot work, but does have some biases because you're enrolling participants that you have access to. So for example, you're just talking to people who are coming to clinic, but you're not talking to those folks who maybe have barriers to coming into clinic for various reasons. And then systematic sampling is when you have random sampling within a defined sampling frame and you're not really looking for specific variability. So for example, you might decide I'm going to interview every 10th doctor or every 5th student from a specific cohort. So now really that we've kind of had an overview of different qual methods and sampling, really thinking about why would we use qualitative methods in implementation science. So really qual methods can be used to address some core characteristics of implementation. So thinking about, we're implementing doing implementation in real world settings that are more complicated and messy than traditional RCTs. Adaptations may be happening and we really want to understand need to understand adaptations and especially what's happening in real world implementation. Qual methods really help us get a contextual understanding. So really understanding the context and being attentive to local, cultural, and community influences. Qual methods can help us get more kind of a complex and nuanced understanding of dynamics and how things are shifting and occurring at multiple levels. And qual methods can help us do kind of multi-component analyses, so looking both at process outcomes and clinical outcomes using qual methods. So really, we think of qual methods as allowing us to understand things in a more in-depth way and really understanding, the why of the what that we're studying. We'd like to touch briefly on rapid qualitative approaches. So when we think about traditional qualitative analysis, it is very time consuming and often there's slower dissemination of findings. And so in implementation science, we're interested in addressing the research practice gap. And if we want to do so in a quick way to get evidence-based interventions implemented, we may not want to use traditional qualitative analysis. So instead, what's gaining increased popularity and what we're using a lot at CIIS is rapid qualitative methods, which can include like true rapid analysis or simply deductive coding, which we'll talk about a little bit. And it's a way to generate kind of quicker methods and results can be cost effective and pragmatic and really action oriented. So we're going to talk about, we're going to talk about inductive qualitative analysis and deductive qualitative analysis. So inductive qualitative analysis is really a bottom-up approach to data analysis. It's kind of the more traditional qualitative or anthropological approach where you are deriving your codes that you're examining directly from the data. And then the researcher, in theory, has no preconceived notions of what the code should be. And instead, you're allowing the narrative or theory to really emerge from the raw data itself. So you'll read the transcripts, decide based on the transcripts what codes you'd like to look for in your qual data, and then build theory from there. And this kind of inductive qualitative analysis can be especially helpful for exploratory research and can help to produce new theories, ideas, and concepts. And so this diagram is showing kind of that bottom-up approach to data analysis. So you're starting with a vast amount of data from multiple sources. You're conceptualizing your analysis. You're doing your coding, your categorization, and then you're developing this overarching theme or theory or model. And so deductive coding is then kind of flipping that upside down. And it's a top-down approach to data analysis. So you're using a predetermined set of initial themes or codes. So you're not looking at the data to develop those themes or codes. You're developing your initial themes from like either from existing theories or models or conceptual frameworks, or from the research question itself, and or maybe organizational categories like the data type or the participant type. And then you're applying these a priori codes to the data that you've collected and then making adjustments as needed. And so with deductive, you kind of have a focused question, you're coding and grouping answers, maybe from different participants, and then you have a specific set of explanations that follow. So I know we touched briefly on rapid qualitative approaches. So really when to use rapid methods is we would think about using it when information is urgently needed or you have a very limited time frame and there's needs for products or progress, or say the person that you're doing the research for, the evaluation consumer is really open to learning and ready to implement changes based on what you're finding. Rapid qualitative approaches are really good when disagreement across stakeholders is low. So if everyone agrees we should implement this intervention and we want to understand it better, that might be a good case for that. And then rapid qualitative approaches can really be helpful if you want to just identify what issues are present and then plan future studies or future in-depth analysis for those. And so we could do a whole lecture on rapid analysis, but just to kind of briefly review some of the steps for rapid analysis is where you have the qualitative data collection, you identify key concepts, you'll do deductive development of the analytic summary template, so deriving your data based on what you've decided a priori and categorizing things appropriately, and then using your matrix analysis and then disseminating relatively quickly your findings. And then now I'll pass the presentation over to Mary Lynn, who will be presenting an example.
Sorry, my mute button was messed up. I apologize. So thanks, everyone. We're gonna sort of, in some ways, I feel like we're coming full circle where we started, that we've tried to follow an example through this entire series for about 8 months. A few examples, but we thought we would wrap it up with just one example. That is a sequential mixed methods study that really used mixed methods, primarily qualitative, but some quant as well, in implementation science. And this was a BMC project, as people know, and you've probably heard me talk about it before, and a huge thank you to the ED who were really transparent about everything and let us publish this and let us do it. So you can move to the next one. So again, this was really about how can we implement Narcan in our emergency department. And so, as you know, we try to, in implementation science, we try to think about, what is the problem? And so the problem here, as we talked about, is overdoses. And this was before like the last 4 years when things have gotten really bad, but it was still a huge problem for accidental death, big problem in our emergency room, not surprisingly, compared to other places in our state and in our city. And we have the thing, right? In implementation science, we talk about the thing, excuse me, or the evidence-based intervention. And so in this case, we had, and still have Narcan or naloxone, nasal naloxone. So that's the intervention. And there was some feeling that, well, the ED is where people end up. That's the first point of contact for people after an overdose, typically, if they're alive. But they weren't really giving out naloxone rescue kits. So basically they were reviving people, but then they weren't giving them out after for people to leave with. And that's a pretty important thing to give people the ability to save their friends or save their partners. And I think, as we know now, there's a lot of naloxone available in many places. Although I was in CVS the other day and they told me it wasn't available. So I was a little annoyed, just was curious. And so what we were learning then is that before we tried this, or before the emergency department did this, they were giving it to about 8% of their patients who came in with overdoses. And it was given out by their licensed drug and alcohol counselors, but there's no way of broadly distributing it. So the hospital leadership, the ED leadership felt like we really need to fix this. We need to enhance uptake. And so their activities around this really created what we considered a natural experiment to study, to see if we could improve. Next, I think May's controlling my slide. So again, what was implemented? Again, we have like strategies and we have the evidence-based intervention. So essentially their strategies, or what was implemented in some ways, it was really their natural experiment, was they did this multi-component initiative. So they created a standing order for a naloxone rescue kit. So instead of, for those of you who are clinicians and for those of you who aren't, instead of someone had to actually write it for each visit, there was a standing order so anyone could give it out. They also increased their coverage. They'd always had those Project Assert licensed alcohol and drug counselors available, but they weren't available 24 hours a day. So they had them still. They also started outpatient pharmacy prescriptions. So you could maybe not give a kit, but you could give a prescription. And then they also had the inpatient pharmacy doing this. So they really said, we're going to buff this up. We're going to really build. But there was no change, basically, from the early results, the first 7, 8, 9, 10 months. The data was the same, teeny decrease, but basically, statistically, it was exactly the same. And it was all done, continued by Project Assert. There were maybe 2 or 3 kits being done by prescriptions or inpatient pharmacy. There were lots of barriers. So that's kind of like the strategies. So they actually contacted us or me and said, we really want to understand what went wrong here. We want to study this. We want to improve this because it's really important. And we want to understand and contextualize the findings, like what went wrong. So that's why we went sort of with the sequential mixed methods. We had these quantitative data. We wanted to figure out and contextualize it. And so we wanted to, when we knew this was a problem, like we're trying to understand this policy and understand the procedures, look at barriers and facilitators, and try to make some recommendations for improvement. So that was the goal. So again, I just said we did sequential explanatory. May talked about this. So the idea is we had quantitative data, and that gave us data that we could use to then try to use the qualitative data to explain, you know, what we were seeing in the quant data and why it went down when we thought it would have gone up. And so the qualitative component was interviews and focus groups with really broad range of emergency department staff, leadership, attending physicians, residents, nurses, nurse managers, nurse educators, the Project Assert, alcohol and drug counselors and pharmacists. And it was also really important that we get a range of people who worked really different shifts. You know, we did a lot of these right before or after the shift and compensated people, but you know, this was clearly pre-COVID, so we could come and talk to people, but it was also really important to work around their schedule. So it was done that way. So that's what we did, interviews. We really use the PARIS. We've talked about different frameworks in this series. We use PARIS, promoting action on research, implementation, and health services. It really drove everything we did. Not always really completely true to frameworks, but I think in this case, we really tried to be true to this because we really wanted to understand, like, what was it, the big constructs, right? Evidence, and evidence means like research, data, but also people's experiences. In this case, patients' experience, staff experience, provider experience. We really wanted to understand the evidence, like Was that the problem? Or was it something contextual in our ED? Was it cultural? Was it leadership? Were there not resources? Was it that? Or was it about facilitation? How that worked? Because if those are the three basic components, and if you do those well, you should have good implementation. Well, we had bad implementation, so we needed to use it. So we really framed everything. And this is a nice, easy framework to use in implementation science because it's pretty broad as well. So that was our model, and we followed it through. So when we created our interview guides, we incorporated those constructs. They're much bigger than this, but I've just provided a few sample questions here. So for evidence, we wanted to ask about their experience with patients who've overdosed, their experience using naloxone. So those were kind of the main kind of, what did they know? The data, everyone knew naloxone worked, but it was really their experiences. And we learned some interesting things about their experiences. About why they felt like this was challenging with patients or their own personal experiences as well. The context, we wanted to know how they saw their role as an emergency medicine provider in terms of doing something like this, like a prevention activity, because definitely saving the life right there with nalox, with Narcan in the ED is the ED clinical activity. Prevention is a different thing. We wanted to talk about that. And we really learned some surprising things. We wanted to know the challenges to implementing this new policy that was supposedly hospital and ED policy in the current environment. And then roles and responsibilities was really important to understand this. And then we wanted to ask them about the facilitation pieces. What would be useful training? What works in your ED? What was done? What did you think? And how can we overcome the challenges? So we, spent, I don't know, 30 to an hour, minutes to an hour with groups having these conversations, which were really fun and fascinating. Go to the next slide. And then the way we did this was, we did inductive coding. May talked about that. So we really started from the bottom, essentially, and we derived our codes from the data. And so we had no preconceived notion about what we wanted to, or what we would find. So we just created codes. And then what we call axial coding, where we put all the open coded data back together and made connections between the categories from the codes and then analyzed it as facilitators and barriers. Then we did do something deductive. So we linked it back, which is not the typical way. I love to work that helps me make sense of things, but it's not always the way. But we linked it back to the three constructs of Paris: evidence, context, and facilitation after we did the analysis. So that was the deductive component. And again, as May said, in implementation science studies, it's really not traditional anthropology type work. And we use a lot of deductive work, combined deductive, inductive coding. I think for me, it's really about the practicality. I'm not trying to create theory. I'm just trying to move to action. That's a big difference in how you use qualitative methods in more traditional social science or anthropology and in CIIS. So, okay, what did we learn? So we learned about these facilitators and barriers. This was one where we found, not surprisingly, given the numbers, more barriers than facilitators, but we did learn there were some facilitators. So the first main thing was this was a real world, I should say world there, not word, driven activity with philosophical, clinician, and leadership support for evidence. So people believed in the evidence. People knew Narcan worked. The evidence-based intervention was not an issue. And what somebody said is, why would you be against Narcan? I can't even think of a rational argument. It's something like condoms, or it's like being against water. So clearly there was a lot of support for that. The other two facilitators or three facilitators, whoops, can we go back? Okay, there was some basic education and training efforts. So they tried to facilitate education and training. I think in some ways, obviously it wasn't as successful as it could have been. Also, having the licensed alcohol and drug counselors, most of whom were in recovery, and 24-hour availability of social workers and pharmacists, those were real facilitators to getting something done. And I think the other thing was they felt like patients could leave the emergency room with the kit in hand. And I'll talk a little bit about why that's important after. So those were facilitators, but comparatively, we had many more barriers than facilitators. So I tried to group them into section because there were a lot of barriers to doing this. So we grouped them into like categories. So there were a lot of protocol and policy barriers. And basically, I think you all know this, like someone tells you what to do, right? If you don't have input. And when they created this policy and this process, they never included the people who had to actually implement it. And one doctor said, the people who designed the policy don't work the night shift. They don't know what it's like to be in there. Another thing, I think it was a surprise to everyone, was that like who to target, really thinking about this, and they felt like important potential targets weren't included. So often, this was really focused in the adult ED, and often patients just would kind of get dumped there, end up there was no one with them, and it's versus like maybe targeting some of the younger patients and the pediatric folks or parents, people who would be maybe more receptive to getting a Narcan kit. There were some just administrative issues. You actually, even though you could leave with a kit in hand, it was all initially paper and there was no EMR based option. So when one of the person said to us, the verbal order is actually a misnomer because a piece of paper is needed and the pharmacy couldn't actually hand it to people without the documentation. So that was hard. Staff didn't really understand the process. There's a lot going on in the ED, and so maybe training was insufficient. No one really thought about, people had different feelings, particularly in nursing, about what the best timing is, given all the other things going on. And it was really hard just to track referrals and orders and kits. There were a lot of workflow barriers. These kind of relate together, but nursing was really clear, and it was, I think, a surprise to everyone that having a verbal order, standing order, was inconsistent with their practice. They aren't allowed to take it, and a lot of them expressed like, we could lose our license. This is inconsistent with current practice. So, because verbal orders apparently were really for life and death emergencies. The paper documentation, probably both logistical and a policy barrier. I think we have a couple of typo issue here, but that's okay. But these are all of like the logistical barriers. We can go on to the next slide. Patient barriers, which I think maybe was a surprise. So when patients have their overdose reversed, it's really uncomfortable and they don't feel good. And so they might just want to leave once it's reversed. It's also people have a lot of social determinants of health and other barriers, adverse social determinants. So one person said patients didn't want their high to have been reversed by Narcan. They don't want to get any to go. But I think there's a lot of issues. Patients are often unaccompanied in the ED. If you hand them a prescription, you got to think about people's priorities, and there's inconvenience of filling it, having to go to CVS. And now I think about it, CVS is gone from here. Now we do have the pharmacies here. There's stigma around that. And there's also potential copayment. So that's a barrier. And then some of the staff, I think we were just relatively consistencies that people had biases about worthiness of patients to receive a kit. And somebody said, sort of the staff are human. There's the deserving and undeserving ill, and the feeling maybe that this is self-inflicted and not a disease. I don't think we people in healthcare are immune to that. We have our own biases. We grew up in a culture where some behaviors are acceptable and some not. People talked a lot about that, about people, I raised myself up by the bootstraps, why, so some of those issues. Staff role and responsibilities were barriers. The clinical staff were just too busy to do this. They have a lot going on in a really busy ED. I think the theory and the intent was that everyone should do this and it's everyone's job. I think we all know that when everyone is responsible for something, ultimately what happens is no one is responsible. So because we think it's someone else's job. So, and no one actually, there wasn't a lot of agreement about whose role it is. I think the sort of, this is a social welfare issue and it's all of our job, in theory, was wonderful, because I think the 2 or 3 people who really were shepherding this or really championing this really believed this should be everyone's primary priority, but it wasn't. And so the doctors would say, it makes to me that the nurses are the endpoint of discharge. It's part of their role and responsibility to have a discharge plan, which included it. Nurses would say no other medications is a nurse's responsibility without an order from the physician. Everyone could have thought it was the resident's responsibility, but no one really knew for sure. And then there were education and training barriers. We have an ED that turns over a lot. People turn over July 1, new set of very busy residents. So staff need training in the policy. And actually, this is before people really even know how to use Narcan. Has to be structured, consistent, and ongoing. Sending an email about a new policy that, busy clinicians may not read, may not be the answer. Training. No one thought about how to incorporate training. You can't just hand people naloxone and the use of a kit. And how do you do it? Like, how do you incorporate training into the workflow? Because from the nursing perspective, this is really time consuming. You maybe need to show a video. You need to, like, how do you do it? Where do you do it? I mean, all these questions had to be answered. Okay. So in conclusion, not surprising, even with really strong support and good evidence for the thing and evidence-based practice, we know it's really challenging to get really good uptake. People's thoughts were identify a target population, start smaller. I think that would have been actually helpful for them getting into practice. Clarify roles. Roles are really important. Good intentions don't take the place of clarity. And make a clear, simple, in this case, EMR-based solution. Nicely, this place did do that. Clarify the ED role. I thought this was really interesting when people talked about our job is to save lives. It's not prevention. And that came up, was a shock to me, and it came up more times than we expected. It is, the ED is not a public health place. I think we've become more and more of a public health place in the last few years, but that is not necessarily the role of an emergency department. And then there were some questions about sustainability and generalizability, which we always think about in implementation science. In this case, the state pays for the Narcan. And so how could we get, this much more engaged with insurance, et cetera, because that may not be generalizable. And it's definitely not generalizable outside of a state like Massachusetts. And then was the LACAD, the Project Assert model of having these folks in recovery available at least 8 hours a day. Is that sustainable and generalizable? Okay, now what we did in our work, as I said, we tied it back. So when we wrote the paper about this, so even when we present it, we basically tied our results back to Paris. This isn't very pretty, but again, in the evidence bucket, we have that there was belief in the effectiveness of Narcan, but really people had little clinical experience with it, and their feeling was that patients weren't receptive. So that's like the big first construct in Paris. In the context, there was great leadership support. There were resources given. But a big contextual thing was what's the consensus regarding the emergency department role? And also, what are the other contextual issues going on in such a busy emergency department? How do you train? Where do you train, et cetera? And then the facilitation style, I think, was the biggest barrier. That it was really episodic didactic training, emails, or run into somebody in the hall and say, this is how we're going to do it. There was no partnership in development of the policy, in thinking about the models and thinking about the training, which is why we think implementation failed. The BMC ED really worked hard to fix all these things, which is to their credit. And I think, is that it? So again, I'll summarize what May and I talked about. So, why do we use qualitative methods? Really to give us the rich, in-depth descriptions of context and behaviors that you can't get through a survey. It may explain different kinds, most common kinds, interviews, focus groups, observation, document analysis. Sometimes we use ethnography, we use we use different things, but these are probably the most common. You can add qualitative methods really to almost any study design. And I think in implementation science, mixed methods is kind of our bread and butter. Because we want to know if things work, if we can get evidence into practice, why, or, and what works and doesn't, and if we can't, why. So that's important. And again, the deductive versus inductive analysis. Deductive analysis uses predetermined themes or codes. Inductive is really emergent from the data. A lot of times we do a little bit of both. I think that's our summary. As May said, this is our last session for this year. We're trying to determine what our education series will look like for next year. These are all available. And I guess we want to open it up to questions. I know there were some chats, but we'd love to open it up to questions.
Good afternoon, everyone. First of all, I want to thank the opportunity to have been participating with you guys since the beginning of the sessions. It was really improving for me as a post-graduation student. In my country, we talk a little bit about some qualitative methods and other ways to do research, but I was quite surprised about all this contents of the implementation series. For sure, really, you know, how can I say, it's different from everything that I had done before in the post-graduation program at my country. Thank you. It was really understanding and really interesting to be here with you. I was in the chat sharing about the project that we have in Brazil about the reproductive health. And it's also challenging to talk about prevention and implementation with training and all these challenges that you are talking today about. And that's why it's so interesting to measure and prove things, because sometimes people understand that a complex phenomenon or complex challenge in health could not be done by, you know, hearing people or coming through diverse voices. And we have to do this because we have to compound a scenario and interventions that could really help people. That's it. Thank you so much for the opportunity to be with you and learn a lot.
Thanks, Karina. I know one of the things we want to do, and we're thinking about how to best do it. I mean, obviously, put any suggestions you have for education activities in the chat. And we're also working on getting input, more broad input about what educational activities would be helpful, you know, in the next few months as we kind of plan and take a little bit of a break as the sort of academic year is sort of winding down. Other thoughts, questions?
And I see some people are hopping off, so I want to make sure we'd love for folks to, we're going to stay on for questions, but would love for folks to fill out the brief survey as well as get that feedback. Yep. Yeah, Renee, you want to unmute?
Yeah, hello. I just had a really quick question that might be like super random, but I'm starting doing a study at Spalding actually, but I'm part of BU Med School, and I know I have access to NVivo, if you know it. And I'm wondering if I could use NVivo for Spalding, or would that not work? Like,
I don't see why you couldn't. Yeah.
As long as you have IRB, yeah. I mean, yeah, it's your data.
Right. Yeah, I was just thinking maybe like with like going across institutions with that.
No, I don't think so. I think it's your data and you're the investigator. So yeah, you should definitely make use of it. And it's great that we have access to NVivo, which is a great, for folks who don't know, a qualitative analysis software that lets you kind of upload your transcripts and do your coding there. So yeah, I think
Yeah.
that would be,
Yeah.
I don't see any problems with that.
You just
Okay.
have access through BU, not BMC. So if you're faculty, I don't know you, Renee, but I'm assuming you're
Yeah.
faculty.
I'm a med student, so
Just download it through your BU address. Don't
okay.
don't try to use, yeah,
Okay. Okay, thank you.
you know, the BU BMC divide lives on. We can get it for BMC people, but there's just an extra step.
Okay, thank you.
Yeah, sure.
Do we let people go?
I
Have
think
a
so.
wonderful summer and
Oh,
we
sorry, I
will.
have one
Oh, go
question.
ahead, Jackie.
Yeah, please.
So thinking about like real world and examples, and I'm working on several initiatives, and they're pretty much like new projects that are being implemented in clinical settings. And I hear, I guess there's no right or wrong, but choosing the framework. So when I think of new programs, I've heard of proctors kind of being something that is there. It gets to, you know, the reach or penetration, acceptability of these new programs. How did you choose, and like, what made Ferris the more kind of like, how does one kind of decide which framework do we move forward with and choose depending on the length of the program, whether it's new or existing, the context, and yeah, just some kind of thoughts on that.
I can start, but I'd love for other people to jump in. So there's different kinds of frameworks. There's like process frameworks, determinant frameworks. Like Proctor and Paris are really different. They're different kinds, they're different. And so this was something where was very kind of early exploratory. We weren't like putting in a set of strategies and really studying those. We were just trying to understand like the determinants of like what had happened. So we chose that. And I just think in our gut, when we looked at that initial data and we saw, despite all these efforts, there was actually no change or a little decrease, but no statistical change. It made sense to explore what was going on. And so it was a nice exploratory thinking about. And so just kind of being familiar with different frameworks, thinking, okay, is a problem here? Are there challenges here about belief in the evidence, the intervention, or experiences? Is it something about how it was implemented, the facilitation? Is it something in the context? So we thought it just made sense. So I think whenever we choose a framework, we're thinking about like, what are we trying to do? What level of framework? What type of framework? There's so many pieces. What I always say to sort of relatively, think Catherine put in a great thing. What I always say, I think for probably 3 years when I first started doing implementation science work, I think I probably used 3 frameworks, one of each type. Then I got better. I think it's really a learning process. Finding some that feel good, you fit, then you learn 2 new ones. I don't know. I'd be curious about Catherine and May and Shane and other folks who've been doing this for a while too, how you think about it. But I think it is like, what is your question? What is your intervention? What is the gap? What are your outcomes? But also, yeah, but also, I don't know, dig into a few that you feel comfortable with, then dig into a few more.
Yeah, I think my approach is similar to Mary Lynn's, but might also be because I've learned a lot of this from Mary Lynn. But I would say, like, I start with, what am I hoping to understand? Am I hoping to understand how to do something, how to get something into practice? That would lead me to a process framework. Am I trying to understand why something does or does not happen? That would lead me to a determinant framework. So that's my first question, which I think is that gets to Mary Lynn's, like, what is the research question? So that's my first question to myself. And then other things that I consider are, is there a strategy that I'm using that lends itself well to one particular framework or another? So in particular, facilitation is part of Paris and IPARIS. And so if you know that you're using facilitation as an implementation strategy, you may want to consider, use of Paris or IPARIS. That doesn't say you have to use one of those frameworks. There are other frameworks that may be appropriate based on your research question, but that's sort of another factor I take into consideration. And then Mary Lynn, you gave this advice actually, I think in our session on models and frameworks, where if you just choose like 1 or 2 frameworks each year to really dig into and to actually use, over the course of a career, you end up becoming very knowledgeable and facile. And I would say like that has been true for me. Like I used IPARIS last year. That was the framework I used. I'm writing a grant now. I'm proposing to use CIFAR, which is a determinant framework. And that's, I think, been a helpful words of wisdom, because there is like a lot to bite off and chew. And so like taking small bites is like very okay.
That's what I was going to say, little bites.
That's really, really helpful. And I don't know if there's time, because I know we're over to the cutoff, but is there a process in which, when you're doing this work in a real world setting, do you socialize like the frameworks or logic models as you are working with like the stakeholders for a better understanding of like what you are doing? Or is this something that's not necessary, that you think you're not, you don't practice really in the work?
I think we try to do in our work in a really, I know it's an overused term, but in sort of a community engaged way. And part of it is educating people. So I think that, I don't know if the rest of the team feels that way, but I think we try very much you can't do this work in a vacuum.
Right.
Yeah, I think it's a great, I think
Great
it's a great question and a great way to approach the work, and may help folks understand, why you're asking the questions you're asking, or
Right.
what the demands are, to contextualize that for them. So I think that's a great
That's
approach.
what my team and I are trying to like create a toolkit of like, well, how do we take these logic models or like frameworks to it, like kind of use in layman's terms, like, and not so research heavy focus, for them to understand like, hey, this is why we're coming in and asking you to like join these focus groups, or like what is the end goal, as we do need their collaboration too with what are the needs of the community, which a lot of the work that we're doing. And so I was just curious about, whether you think that's a good thing to, I guess, put a lot of time and energy and effort to like create such a toolkit to socialize with different audiences. Yeah,
no, that's great. Stay in touch with us. Let us know how it goes.
Yeah, definitely.
Thank you so much. Thank you.
Thank you. Thanks all, and we will feel free to be in touch for a consult or an email or anything, and we'll see you in the fall.
Thank you.